Okay, so this is Hormone Therapy FAQ. I have done this member event a few times in the last year. I study at the North American Menopause Society, the International Society of Gynecologists, and I want to make sure that while all of this information is accessible to both physicians and consumers, women, the layperson, it's not always easy to understand. And so that's why I want to do this. This is my interpretation. It is not my job to tell you to take hormone therapy. It is my job to convince you that your health is worth having an investigative conversation about what the benefits of hormone therapy might be for you. And then you get to choose the journey that's right for you. So let's do this. Welcome, everyone. My name is Shirley Weir. I'm the founder of Menopause Chicks. I host a private online community on Facebook, which might be where most of you know me from, but I think there's also some people joining us from Instagram and LinkedIn. So welcome. I'm 56 years old. I founded Menopause Chicks a little over a decade ago based on my own journey. And now I am here to support yours. And I love what I do. I consider it an honor and a privilege to do this work. And I especially want to thank you and congratulate you for taking time out of your busy schedules to learn about your health and to get answers to your questions. So that's why we're here. Oh yeah, I already said this off the top. I'm going to say it again because it's really important. My job is not during this session or at any other time to convince you to take hormone therapy, but it's really important that all of us understand that our health is worth having a conversation about the potential benefits. And we're going to get into that a little bit later, but I'll right now just tell you one of the biggest misconceptions can be that hormone therapy is for the treatment of symptoms. And yes, while that is true, it is much more than that. It is about investing in women's health for the next 30 to 50 years. So we will get into some of those statistics in just a few minutes. This slide I left in, it's from the May edition of this hormone therapy event, and a segment had just appeared on CBC, the national. So I live in Vancouver, British Columbia, Canada. CBC is our national broadcaster, and it's a really great segment. If you want to look it up at CBC, the national, it's about 9 minutes, and there's a ton of really good information there, but there was a few things that were left out. And so that's why I created this slide. It's hard to pack in what we're going to talk about tonight into 9 minutes. And the reason why I'm mentioning that is because I know firsthand that for decades, women and men have been making health decisions based on headlines and hearsay. And we just simply can't do that in today's climate, in today's environment, because we have social media, we have all these memes, we have so much misinformation. It is really hard to corral it in. And so again, that's why I'm so grateful that you're here tonight and that you're eager and curious to learn about your health. Okay, so this is the reason why we're having this conversation. What if what we do now could significantly decrease future rates of women's heart disease and stroke? It's the #1 premature killer of women. Every 22 minutes in Canada, a woman dies of a heart attack. What if what we did tonight could significantly decrease rates of dementia? Dementia affects more women than men. What if we could turn down the dial on osteoporosis? Now, those of you that follow me, you might like kind of tune out maybe when I talk about bone health and osteoporosis. There's not really like anything that's too sexy when we're talking about bone health. And I'll be honest with you, when I'm talking to a woman who's maybe at the tail end of perimenopause, let's say, and she's dealing with waking up at 3 a.m. and brain fog and heavy bleeding that's debilitating and affecting her quality of life, it's really, really hard to talk to her about, oh, you got to take care of your bone health. You've got to prevent osteoporosis. And bone loss, as you know, is so silent. It's just not top of mind. But here's the thing. We have this window of opportunity to invest in our bone health. Women lose 20% approximately of our bone mass in the first 5 years following menopause, our menopause date. The first 5 years post-menopause, we lose 20% of our bone mass. What if we had an opportunity to prevent that? Well, we could turn on the dial on the statistic. We could change that from 1 in 3. The current prediction right now is that 1 in 3 women will break a bone due to osteoporosis. And again, you might be thinking, surely not a big deal. You know, if I break my wrist, so be it, I'll get a cast. Actually, what we're talking about is women falling and breaking pelvises and breaking hips. And that can lead to immobility. It can lead to incontinence. It can slow down brain function. And it's just such an impact on our own quality of health, on our close circle of caregivers and how it influences their life, and of course our impact on the healthcare system. So, okay, that's my soapbox about bone health and osteoporosis. Vaginal dryness and vaginal atrophy affect almost every single woman in postmenopause, and 8 million doctor visits per year are the result of urinary tract infections. Anyone can get a UTI, men, women, any age, but reoccurring UTIs are most common with women in postmenopause. And while you might be able to get a prescription for antibiotics for the first one or the second one, after the chronic antibiotics are prescribed, they become less and less effective. And so what if we could today, what we're doing, decrease rates of UTIs? And this is important maybe for you and your health, but you might have a mother, an older sister, an aunt, a grandmother who needs this information too. So I hope you'll take snippets of what you hear or learn here tonight and pass it on to all the women that you love. And then of course, finally on the list is what if we could decrease future rates of incontinence? Incontinence is the number 2 reason why a woman is admitted to long-term care. Number 1 is dementia. And incontinence is very costly, not just to quality of health, but to our wallets as well. So the goal for today is is to make sure that we're moving towards a situation of shared decision-making. So that's decision-making by you with your health team. So your job is to get informed and then choose the journey that's right for you. Hormone therapy is very individualized. We're going to talk about a lot of generally speaking things tonight, but then we have to take that generally speaking information to our healthcare provider and have a conversation about what does that mean for me. It also requires regular reviews. It's not a one and done prescription or protocol. It is something that once we start hormone therapy, we have to be checking in with our prescriber at least once a year, but maybe even more often when we're first starting, because things can change. Hormones are constantly fluctuating, and nothing replaces that personalized consultation with a woman's midlife hormone expert. Third thing, but maybe should be number 1 on the list, is that we need to understand risk, real risk versus relative risk, versus real or personal, our own personal risk. And we used to say hormone therapy requires an individualized risk assessment. But now we say hormone therapy requires a benefit versus risk assessment. And that's really important because, there's a risk to everything. There's even a risk to not doing certain things, and that cannot be understated. So benefits versus risks for you and your own personal health situation. What we're doing tonight is not a deep dive on the Women's Health Initiative study, which you may or may not know about. The WHI, or Women's Health Initiative study, was a study that had really good intentions. It was started in the mid-90s. It came to an early halt in 2002. That led to a whole misinterpretation of results, red flags being raised, a PR nightmare. We're not going to spend a lot of time talking about that because, for goodness sakes, it's 20 years later. We've got information for you tonight that is from 2022, so July 2022, less than a year ago. The North American Menopause Society released its position statement on hormone therapy. I'm going to walk you through the key pieces of information that you need to know. And last week, so it's June, I don't know what it is, June 7th, 2023. And last week, the North American Menopause Society also released a position statement on their recommendations for non-hormone treatment for those women that need to pursue a non-hormone treatment. So I'm going to give you the highlights of that as well. Okay, so I love to start here because I think sometimes we fail to remember that we're really the first generation to turn 50 and have 50 more years to plan for. And that doesn't mean that, your grandma, she may have lived to 100 or even beyond. But the reality is that more of us from our generation is going to live to see 100. And it is a conversation about quantity, but we're going to make a conversation about quality. And here's the second thing you need to remember. It's not too early and it's never too late to learn about our hormone health. Now, I started this work, as I mentioned, over 10 years ago, and it was pretty lonely. I celebrated my 10th birthday last fall. It's a friend of mine at a party. It was pretty lonely. There weren't a lot of quality health resources for women navigating perimenopause to menopause to postmenopause. Now, today, there are lots of conversations happening about menopause, and that's a good thing, but it also comes with a bit of a cautionary flag, and that is more conversations don't work if they continue to perpetuate myths and misinformation. And that's why the mission of Menopause Chicks is to make sure that I can point you towards quality, verified, evidence-based information that you can then take to your health team and make the decision that's right for you. And Gloria Steinem has a great reminder. Our first challenge is not always to learn something. If you're here learning about hormone therapy for the first time, your first challenge might be to unlearn what you thought or what you assumed, or what maybe some myths and misconceptions or generational stereotypes came along with your previous learning on this topic. So let's do that. And before I forget, the recommended prerequisite for tonight's event was or is the Menopause Masterclass. I hosted a live masterclass last night. It was amazing. If you didn't have a chance to attend or watch that yet, it is available on demand at menopause-masterclass.com. Okay, so in that class, I talk about this umbrella. I'm not going to go through this in too much detail, but this is a quick recap. This is the menopause is an umbrella term image. And the reason that I do that is because we're really talking about hormone health before we reach menopause or before 12 period-free months, and the hormone health phase of life called postmenopause, which is every day after we reach menopause for the rest of our life. Hormone therapy is generally not prescribed in perimenopause, except it might include the birth control pill, which is a form of hormone therapy, the IUD, which is a form of hormone therapy, even, hormone therapy as an umbrella term. It can include tamoxifen, which is a treatment for breast cancer, which is a form of hormone therapy. So it is important to remember those umbrella terms. And I was just getting ahead of myself here. This is the umbrella image for hormone therapy. On the left, you have those examples that I just gave. In the middle, you have that date of menopause. And then most of the conversations about hormone therapy will either begin in that, final 12 months of perimenopause, or after a woman has reached menopause, and then she's having a conversation with her healthcare team about what are the right hormones for my age and stage, what is the right dose for my age and stage, what is the right mode of delivery of that hormone therapy that has the highest efficacy rate. So another way to say that is what's the best way to take this hormone therapy that's going to, my body is going to absorb it the best, but also that it has the highest safety profile. And most often, bottom right-hand corner right now, in postmenopause, women will be taking estriadol, which is one of 3 forms of estrogen that women make in their body when cycles are regular, and progesterone therapy. And estriadol and progesterone therapy are approved for 3 things. That doesn't mean they don't have a whole host of other benefits, but hormone therapy is approved for these 3 things. One is the treatment of vasomotor symptoms, AKA also known as hot flashes and night sweats. Hormone therapy is approved for the treatment of vaginal dryness and vaginal atrophy, or symptoms of what is known now as genitourinary syndrome of menopause. A really big mouthful. I don't know a woman or a physician who actually even says that phrase, but what we're talking about is vulva health, vaginal health, bladder health, urinary health, the pelvic floor in its entirety. And the third thing that hormone therapy is approved for is the prevention of bone loss. That's why I was on my soapbox about osteoporosis a few minutes ago. I apologize, the screen is fuzzy, but I throw it up here because everybody is different. Of course, you can't draw a picture of hormones. They're fluctuating all the time, especially in perimenopause, morning to night, week to week, day to day, month to month, year to year, fluctuating all the time. But generally speaking, this is a really great snapshot of what our hormones look like over time. The purple line is estriol. It fluctuates in puberty, and then it fluctuates again in perimenopause, sometimes quite wildly. Progesterone is the hormone that's produced in the second half of our cycle. Estrogen is the hormone that's produced in the first half of our cycle when cycles are regular. Progesterone starts to decline in that last few years of what is known as our reproductive years, and continues to decline right through perimenopause into postmenopause. So on the far right of your screen, you're in postmenopause. You can see the purple and the green line. Estrogen and progesterone are declining or have declined. They're low, low, low. And the red line, which represents symptoms, are high, 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 high. Okay. And right here is usually where symptoms start to really wreak havoc on a woman's life. And another way to illustrate that is through a roller coaster. So you think of estrogen as being at the top of the roller coaster and progesterone being at the bottom. A great way to illustrate postmenopause is by using the cliff diver. So it is possible for us, many of us, to sail through perimenopause. It's not always like this. This is like the extreme situation. And like I said, that can change day to day, week to week, month to month. But in postmenopause, and what many members that I meet in the menopause chicks community on a regular basis are kind of surprised by, is that they reach menopause, early 50s, and they weren't informed or they aren't prepared for that steep decline of estrogen, and progesterone has already started to declining. So they're really left unprepared and knowing what to do. And if you've watched the masterclass, you'll know the roles and responsibilities of estrogen and progesterone, what they do for our body before we reach menopause. And then we're like asking our body to be like, oh, hey, can you do this, this, and this for the next 3 to 5 decades? And oh, by the way, I'm not going to give you the same, you're not going to have the same ingredients that you once had. So it's a bit of a challenge, and I'm sure that many of you know that. And I can't remember why I included this again, but I just really want to come back to this because this is why we're having this conversation. In the Menopause Chicks Masterclass, I make sure that everyone can walk through this pyramid. This pyramid is in a particular order for a reason, and it's not because hormone therapy is the least important. It might, in fact, be the most important. But what I want you to take away from this pyramid in today's hormone therapy class is that we can't skip to the bottom of the pyramid. So whatever it is, and I know that many of us will have experiences that are new or disrupting our quality of life. We think, oh, it must be menopause. Oh, I must need hormone therapy. I took hormone therapy and it didn't fix my sleep or my joints or whatever it is. And so we're frustrated and disappointed by that. And what we really need to do is, first of all, understand the roles and responsibilities of estrogen and progesterone and know that that is an option on the pyramid, and get really curious about what else we need to do when we're prioritizing our health. Do we need to pay attention to a lifestyle, how we eat, move, and sleep? What are we doing to manage stress? Are we missing anything nutritionally? So many women are iron deficient or magnesium deficient, or need support with vitamin D, super important, or omega-3s for brain health and heart health. Many women also have other health conditions that need to be investigated and addressed. And one of the most popular is thyroid. So it's great to say, hey, I'm going to have this conversation about what hormone therapy might hold in terms of benefits for me, but we can't skip all of the other rungs of this ladder. Okay, let's get into questions about hormone therapy. The reason that I have the Rubik's Cube is that hormone therapy is complex. It's a bit like solving a puzzle. It's also a bit like conducting an orchestra. I mean, you notice there's no pictures of hormones on the screen here. We don't actually know what hormones look like because they're messengers between the brain and the ovaries. But the analogy of a puzzle or a Rubik's Cube or conducting an orchestra and kind of keeping everything as healthy as possible, well, let me know which analogy works best for you when you think about hormone therapy. But one of the reasons I have these analogies to teach women is because often they think it's a one size fits all. It's like, I just need this and all will be well. And often hormone therapy does need to be tweaked. And as I mentioned earlier, it needs to be monitored or changed to make sure that it is one size that fits for you, not for all. This is the North American Menopause Society position statement on hormone therapy. As I was saying, it came out last July. I'll read you some of the blue. And this is available to everyone. It's at menopause.org. You can download it. Your doctor has access to it. Hormone therapy remains the most effective treatment for vasomotor symptoms, aka hot flashes and night sweats, and the genitourinary syndrome of menopause, and has been shown to prevent bone loss and fracture. Treatment should be individualized using the best available evidence to maximize benefits and minimize risk, with periodic reevaluation of the benefits versus risks of continuing therapy. For women aged younger than 60 years or who are within 10 years of menopause onset and have no contraindications, the benefit risk ratio is favorable for treatment of bothersome vasomotor symptoms. So medical papers like this, and I know I have read this numerous times, but we have to kind of sometimes take a step back and think about context. And medical papers are often written and studied in the context of treating symptoms. And that even comes through in this, although hormone therapy is unlike any other prescription medication. So we're to take all the prescriptions in the world and then carve out hormone therapy. What makes it different is that hormone therapy, we're giving the body back something that it used to make on its own. In all other prescriptions, we're giving the body something that it doesn't make on its own, a molecular concoction, chemical structure of some kind that's going to benefit or treat a particular symptom. Let me know if that makes sense for you. And the agenda for these FAQs that I'll start to go through in quite rapid fire format, if that's okay with you, because I want to leave a good amount of time at the end for your specific questions. We're going to talk about what it's used for, the definitions of bioidentical versus non-bioidentical, route of administration and efficacy, FDA / Health Canada approved hormone therapies versus compounding, and your most common questions. Hormone therapy, I've already gone over this. This is the 3 things that it is approved for. This is an area, bioidentical versus non-bioidentical is an area that comes with a lot of confusion. Let me know if that is one of your questions. I can tell you emphatically, there is no such thing as natural hormone therapies. So be careful of any marketing words that you might encounter and question those providers that use that. The only natural hormones are the ones that we make in our ovaries ourselves. So if someone tells you that they're taking natural hormone therapy, it must mean they are extracted hormones from their girlfriend's ovaries. Like, it just isn't. Every hormone therapy is made in a reputable manufacturing plant by a reputable pharmaceutical company or in a lab, and therefore that is not natural. Both bioidentical hormones and non-bioidentical hormones are FDA Health Canada approved. There are examples of both. The term identical is a bit misleading. What it really means is that there are different molecular structures of hormone therapies, and bioidentical are similar. They have a similar molecular structure to the hormones that we used to make in our ovaries. And non-bioidentical hormones have a different molecular structure than the hormones made by our own ovaries. So an example of non-bioidentical hormones would be the birth control pill or the IUD, the Mirena, which is a brand name for an IUD that's hormone therapy included in it. So it really, these terms just really help to differentiate between the active ingredients that were used to make the hormone therapy. Compounding simply means a customized hormone therapy, and compounding is available across the board. I mean, I have my dog's medication compounded. It means you can go to any pharmacy. Pharmacies are, they have all of the technology, almost everyone has the ability, or they can send it off somewhere to be compounded. If you are, if you've ever been prescribed a capsule medication that is too big for you to swallow, you can ask your pharmacist if they can compound it into a liquid or a gummy or a something. It just means customizing, and it allows for customizing. And when it comes to women's menopause hormone therapy, compounding can be valuable for customized doses or customized modes of delivery. It's not, for the reason, because it's customized, it's not FDA Canada approved. It's not the first line that you go to, because there are bioidentical hormone therapies that are available. Any prescriber can prescribe them. They're available at any pharmacy. So this would be, if a customized approach was needed, then you would be looking at compounded hormone therapy. Route of administration simply means how we take it. So the options are oral, transdermal, which can be in a cream, a gel, or patch; vaginal, which can be a cream, a gel, a ring inserted into the vagina, or a suppository. Other routes of administration would include the IUD, which is FDA Health Canada approved, and pellets, which are not. And pellets are more common in the United States than they are in Canada. They're not approved. They have some very limitations. If anybody has questions or they're weighing the pros and cons about that, let me know. And then when you're making decisions, you probably wouldn't make this decision by yourself. You would do it as part of a shared decision-making conversation with your prescriber. But when decisions are being made about route of administration, bullet number 3, you want to be able to know what the #1 efficacy recommendation is. So how effective and safe it's going to be for you. And so here is, I'm going to give you the answer to that right now. Estriadol, or estrogen, is taken transdermally. Transdermal, that means applying to the skin. Transdermal estrogen has the safest risk profile over oral estrogen. And that is with respect to the prevention of blood clots, stroke, and changes to our cholesterol. So this is my estriadol. It's transdermal. It's a cream. I don't know if you can see that or not. And then it's just applied to, whatever part of your skin that your pharmacist recommends. It's usually like a thinner part of the skin, maybe the inside of the arm or the inside of the thigh. And an example of transdermal estriadol as a brand name would be Estrogel or Divigel. Progesterone, on the other hand, has the highest efficacy rate when we take it orally. So the name of progesterone is oral micronized bioidentical progesterone. An example brand name, most common, is Prometrium. There are other generic brands that make oral micronized bioidentical progesterone as well. The reason this has the highest efficacy rate is that it does the best job at protecting the lining of the uterus. Oral progesterone is also approved for the treatment of hot flashes. And so if you have not yet reached menopause, you're in the last year or two of perimenopause, but you're experiencing hot flashes, which is when the majority of women do experience hot flashes, progesterone therapy can be prescribed before you reach menopause, and it is approved for the treatment of hot flashes. What about progesterone cream? I have to include this here because progesterone cream is available over the counter in the United States. And it's probably available, online to Canadians as well. It's not FDA or Health Canada approved. And I really caution you in doing it yourself, because I don't know if you're getting the right amount, the right dose. And hormone therapy is too important, and your health is too important to not have this protocol guided by an educated, experienced hormone expert. So I would say no, unless there's some reason why you can't take progesterone orally. And one of those reasons might be that the progesterone you've been prescribed is contained in peanut oil and you have peanut allergies. So, there's always a reason. There's always like a one-off or a what if or a customized reason. And that's why we have to explain all of the options that are available. And then you have this information to discuss with your healthcare provider. An excellent chart in sorting out that information that I just shared, this is just one snippet of it, is at womenlivingbetter.org. This is my friend and colleague, Nina Kozlov. She has taken all of the brand names and put them into columns so that you can see what is bioidentical, what is non-bioidentical, and the route of administration is clearly illustrated there. I love the chart so much. There's absolutely no reason for me to recreate it because Nina has done such an amazing job with that. So, are there exceptions? Yes, I just said there's always exceptions, and that's why we're talking through everything. Are there combination treatments? That's a great question. Yes, so you may have heard of patches that are combination treatments. There are patches that are non-bioidentical, and there is one oral treatment that is bioidentical, that is a combination. So that would be very specific. Why would you need a combination? It might just be personal preference. It might be something that helps a woman be more compliant, because it is really important that we're compliant with these therapies. There might be other reasons too. Can you take hormone therapy vaginally? Yes, 100%. And when we talk about hormone therapy for menopause, most often we're talking about the hormone therapy examples that I was just sharing with you that are taken systemically. Everyone who has reached menopause can use vaginal estrogen, and there is no timeline. There's no guideline. There's no deadline for how long you can use it. It is really supportive of vaginal health and therefore really supportive of urinary health, taking care of the urethra and just taking care overall of pelvic floor, i.e., helping to prevent incontinence, helping to prevent prolapse. So that's a really great question and reason why you need to get curious about vaginal hormone therapy. And finally, can you take progesterone orally, estradiol transdermally, and still need vaginal hormone therapy too? And the answer is yes. Treatments taken vaginally for vulva and vaginal atrophy, or GSM. Sorry, I kind of got ahead of myself there. There is no timeline. They are available in cream gels, ring suppositories. They're all applied locally. Estrogen example brand names would be Vagifem or Imvexxy. And there are some new things that have come onto the market. Some of these as recent as 2023, and I want to share those with you. So first of all, hyaluronic acid vulva and vaginal moisturizer. This is the Feel Amazing vulva and vaginal moisturizer that was co-created by menopause chicks. It's not new. It was formulated in 2019. It was Health Canada approved, however, in 2022, and you can order it at moisturizeyourvagina.com. Hyaluronic acid is a naturally occurring molecule that our bodies used to make on its own, and it started to decline in probably our 30s or 40s, and then it declines more significantly post-menopause. Hyaluronic acid as a treatment for vaginal dryness / atrophy is the first line recommendation by the North American Menopause Society and by the International Society of Gynecologists. So first line recommendation means do this first, use it preventatively or use it to help manage vaginal dryness until you might need a prescription for vaginal estrogen. or DHEA, which is the second thing on this list. So DHEA is another hormone. When it's applied to the vagina, the body automatically converts it to the amount of estrogen and testosterone that we may need. And DHEA, or brand name Intrarosa, has been approved in the United States for a number of years. And in November of 2022, it was approved for use in Canada. And then in 2023, Osphena, which is the brand name for an oral medication for vaginal dryness, was approved for use in Canada. And you might be saying, at least this is what I said first, an oral medication for vaginal dryness. But yeah, I mean, if it's effective and it's personal choice. And I find this quite exciting that the menu of options, when vaginal health and vaginal dryness has been so overlooked for too many years and had too many people suffering and such a small percentage of women actually receiving treatment. It's like heartbreaking, actually, the statistics. But when we have more options, then it means that there are more conversations and there are more choices on the menu for you. And if you are, struggling with compliance, if you like to take all your vitamins and supplements and medications in the morning and you like to take them all early, then that would be something that you might be considering. I could go through this list. These are some common questions, but I think I would rather just jump into your questions in the queue. So I'll come back to that if I need to. Just as a review, because I talk about with that big red arrow about what if we could significantly decrease the rates of heart disease, dementia, and so on, I just wanted to review what I am saying. So hormone therapy is not yet approved for the prevention of heart disease. But we know two things. One, estrogen before menopause is very protective of the woman's heart. Our hearts are different than men's. We have estrogen. Estrogen plays a key role in protecting our heart health. When we don't have that estrogen, the rates of women's heart disease go up significantly post-menopause. So hormone therapy is not yet approved for the treatment of heart disease. One of the reasons for that is because less than 12% of all research dollars go into women's health. So then if you think of women's health and then you think about all of these questions that we have that we would like to explore, there isn't enough. The second thing that's important to know is that the Women's Health Initiative study, that study that I said was flawed and that was halted early, and that there was sort of a lot of damning results that came out of that. The initial reason of why that study was started in the first place was researchers wanted to show that there was a correlation between hormone therapy and preventing heart disease. And they wanted 30,000 women. They wanted to follow them for 30 to 50 years, and they couldn't regroup for it. And it was just on and on and on. It was not a great study, but the initial intent was there. And now, 20 years later, we're still living with devastating results of women's heart disease, and really nothing definitively that points to hormone therapy as a benefit, although we know that estrogen is very protective of women's hearts. Same thing can pretty much be said about brain health. Not yet. There's absolutely no evidence that says hormone therapy will prevent dementia. However, there's people studying it. And there's one study in the journal of Alzheimer's that shows that estrogen combined with quality unmedicated sleep, combined with omega-3s, does show positive or favorable results in preventing dementia, preventing Alzheimer's. Breast, we need to understand true risk, and I've got a couple of slides on that coming up next. Bone health it is approved for. So check mark there. Hormone therapy is approved for the prevention of bone loss. And vaginal and pelvic health, another check mark there. Hormone therapy is approved for treatment of genitourinary syndrome of menopause. Okay. This is one of the aha moments that I've had in doing this work. And that is one is that we're not taught about how our hormones work when cycles are regular. And two is, as a society, we've never really been taught about risk. We hear headlines, but we don't always have the opportunity to dig through and say, hey, health team, what does that mean for me and my quality of life? And how does that marry in with maybe some of the existing health conditions that I already have? Or are there modifiable risks? And that category includes things like how much alcohol I drink, my weight, how much I exercise, overall lifestyle. So what are all of those factors? How does it interpret to my risk? So let's talk about risk. What should we be asking about breast cancer? Well, the first highest risk for getting breast cancer is having breasts. And the second highest risk for having breast cancer is age. Our risk for breast cancer goes up as we get older. And then there's everything else. As I was just saying, exercise, weight, genetics, all of those things come into play, as well as we know from recent research that just was modified and came out in January here in Canada about the consumption of alcohol. And I have a video, it's not going to play, but you can go to my YouTube channel, so youtube.com/menopause-chicks. Please watch the video with Dr. Bal Pawa. It's called, what's it called? It's called Cheers and Fears. And she does an excellent job of explaining in this video about how, some of her patients are so scared of getting breast cancer from hormone therapy. And as she's going through individual benefit versus risk profiles, she's asking, well, how many drinks do you have a week? And this one patient that she tells in this particular story said, oh no, not much, just a couple of glasses of wine with dinner. And so Dr. Paula writes down 14. And the patient, of course, is alarmed. She's like, I didn't realize I was having 14 alcoholic beverages per week. But what she really didn't realize is how she was putting her potential for breast cancer at risk far greater than being on hormone therapy by her alcohol consumption. So it's definitely worth a listen if you can. So the key points, this is a screenshot from the position statement from the North American Menopause Society on hormone therapy. And here's some key numerical interpretations. So the risk of breast cancer related to hormone therapy use is low. The estimates indicate a rare occurrence of less than 1 case per 1,000 women. So 1 out of 1,000 equals, it's actually 0.001%, right? And then what happens is that number goes up when she has been on hormone therapy for 5 years or more. What's really important is that we put that into the context of what are some of the other risks in our life. And I know lots of lots of people who are scared of flying. And flying is probably one of the safest modes of transportation, but yet our chance of being killed in a motor vehicle accident is much, much higher. So having that risk in context, super important, and then really taking it down to the individual level and making sure that you understand what the real risk is for you. This slide is for anyone who is already on hormone therapy and is not yet feeling amazing. And that should be the only side effect of being on hormone therapy, is that you feel well. But because this is an orchestra that we're conducting, because it's a Rubik's Cube, the questions to ask or to take to your prescriber, if you're on hormone therapy and you're not feeling great, is, am I taking the right hormones for my age and stage? Am I taking the right doses for my age and stage? Am I using the mode of delivery with the best efficacy rate for me? And when should I book my next review appointment? Now, I just want to quickly include that last week we got new information, new position statement on non-hormone therapy options that are available. This is for the small percentage of women who cannot take hormone therapy because of pre-existing maybe estrogen dependent cancer or cardiovascular disease. Now this looks a bit messy, but I screenshotted it and put it in different colors for a reason. I would have written this in a different order. I put, see the red star. The conclusion is, and this is really, really important, hormone therapy remains the most effective treatment for vasomotor symptoms and should be considered for women who are within 10 years of menopause or under the age of 60. And for women who are not good candidates for hormone therapy, it's really important that their health professionals don't just say, you're not a candidate and wave goodbye. It's really important that those health professionals have access to the full menu to give women options so that they can have restored quality of life. All of that said, think about what we talked about tonight and keep in mind that this conversation is only about the treatment of hot flashes. It is not about how we address our vulva and vaginal and pelvic and urinary and bladder health. It is not about how we prevent bone loss or prevent osteoporosis. And this is, again, where more conversations are somehow contributing to this notion that all menopause means is hot flashes. You just have to find a way to treat your hot flashes and all will be well. Well, you know that that's not true. And one of the main key reasons for that is that we have to prevent that bone loss that is inevitable when estrogen and progesterone decline after menopause. Very, very quickly, there are recommended therapies and non-recommended therapies. The recommended therapies include CBT, cognitive behavior therapy, clinical hypnosis, and even some SSRIs, which are antidepressants. They would be prescribed in an off-label format, and they have the off-label side effect or benefit of eliminating or reducing hot flashes. They are not treating the root cause of the hormone decline, but for somebody that needs that support, that is the recommendation. Not recommended are things like paced breathing, supplements and herbal remedies, cooling techniques, exercise, yoga, mindfulness-based intervention, relaxation, soy foods, and on and on and on the list goes. And you know, you've probably been subjected to a lot of the marketing from companies and organizations that believe they have the magic wand for women in menopause. What they probably do is have a really great business case. Whenever you insert 1 billion women into a spreadsheet, it usually gets business financing, but this is the science, this is the data, but this is only about the treatment of hot flashes and night sweats. Just a reminder, if you haven't already, jump into the Menopause Masterclass, tell your friends, it's available on demand. And if you're not already, I would love to see you in the Menopause Chicks community. It's a private online community where I spend most of my time, and you probably already know that because you belong. So I'm going to stop sharing my screen. I want to see what questions you have, And again, I will remind you that if you have to jump off the call, I'll stay till all the questions are addressed. If you have to go, watch your email at this time tomorrow. You'll get a copy of the replay. That replay can be watched, rewatched for the end of time, but share it with your friends and even share it with your doctor if you want to. And then those members who have taken the masterclass, that includes one-to-one texting with me. So if there was something I said tonight that maybe ignited more curiosity, or that you just want clarification on, or if you really want to prepare for your next health appointment, for that conversation, I am happy to work with you on script tips. So, okay. Might be stupid and come from my mom's fear growing up, but I'm irrationally worried about the side effects, and also if there are any cancer-causing issues with hormone therapy. I hope that I helped to address that tonight, Allison. I think it's not necessarily about side effects, because the only side effect of hormone therapy ought to be that you feel amazing. You're giving your body back what it used to make on its own. You want to be taking the right hormones for your age and stage. You want to be taking the right doses, and you want to be using the mode of delivery that has the highest efficacy rate. Fear is interesting. I can't reduce your fear. I can only provide you with quality information, and then you have to rationally, I'm using that word because you did, approach that with curiosity, hopefully surrounded by a quality health team. I will invite you to revisit the umbrella of hormone therapy, because it's a fascinating situation. I don't know if you've been on birth control pill or if you've ever had an IUD, but as a culture or society, we've never been afraid to give women hormones when they didn't need them. And that is a birth control pill. I mean, yes, they need it for contraception if it's your contraceptive method of choice. I am not slamming that in any way. I'm just saying that prescribers and women have really had little hesitation over time in taking the birth control pill, but we've had a lot of hesitation in taking hormones when our bodies actually need them. So I hope, oh, it did help. Okay, that's cool. If you need any more clarification on that, let me know. I am facing the possibility of taking tamoxifen due to breast cancer. Wow. As a result, estrogen therapy is on hold. I understand. How might I support my postmenopause symptoms while experiencing the side effects of an anti-estrogen medication? Very specific, very individualized question. I hope you have an amazing doctor. I hope that your health team includes more than your oncologist, and that maybe you can invite a women's hormone health expert onto your team for a consultation around this question as well. As you may have heard at the end, there are many approved non-hormonal treatments. I don't know what you mean when you say postmenopausal symptoms. Maybe you mean hot flashes and night sweats. So there are non-hormone therapy treatment options. And if you need me to point you to that information so that you've got the best summary for your next health conversation, I'm happy to do that. The ultimate goal is you're navigating a health concern, and it's going to be okay, but you deserve to feel the best that you possibly can during that treatment journey and post-treatment journey. So I wish you continued health, and let me know how I can best support you. How about DHA transforming into progesterone? Your thoughts? I don't know it's about my thoughts, but I do know that I interviewed Dr. Kelsey Mills, who is a gynecologist in Victoria, British Columbia. She is a North American Menopause Society certified practitioner, and I can include that link for you. I'm sorry, I've been talking too much today. I can include a link to that interview with Dr. Mills, where she explains how DHEA therapy converts to estrogen and testosterone when it's used for vaginal use. I don't know too much else in addition to DHEA beyond that education that I received from Dr. Mills that night. I'll be honest with you. Do you take both of these in the same time period? I'm not quite sure what you're referring to as both of these, but I think you might be referring to progesterone and estriadol, and maybe you're asking me personally what I do. So I take Prometrium at night. Progesterone this is my progesterone, brand name is Prometrium. Progesterone is very supportive of mood and sleep, and it's also highest efficacy for protecting my uterus. So I take it at night because it produces a sound sleep for me. And then my estriadol, I take morning and night, and that's how it was prescribed to me. You are going to want to follow the prescribing instructions that are given to you. How often and for how long do you take hormone therapy? You'll notice, everyone, that when you say HRT, which stands for hormone replacement therapy, I say hormone therapy. So I don't say replacement. It's actually called menopause hormone therapy, or just hormone therapy as the umbrella term. How often do you take it? How often and for how long? So not quite sure I understand the question, but the recommended time frame for when we start hormone therapy is when we're under the age of 60 or within 10 years of menopause. I started, I'm just going to grab some water, sorry. I reached menopause at 49. I started taking progesterone therapy at 48. Once I reached menopause, I added estriadol. Generally speaking, estriadol or estrogen is not prescribed until post-menopause. Of course, there are exceptions for that, but progesterone therapy can be prescribed before menopause because it has already started to decline. And then for how long, to answer that question. So there is no recommended deadline for how long you would stay on hormone therapy. I don't have any intentions of quitting hormone therapy. That's me personally. My sister started hormone therapy when she was 36. She was at 36. She's a healthy 66-year-old now. She had cancer as a child, and we believe that the radiation treatment she had when she was 6 years old damaged most of her egg follicles. So she didn't get a period until she was 18. She stopped menstruating when she was 36, and she is a healthy 66-year-old, and she has her bone density checked on a regular basis, and manages all of her other health markers as well. What was I going to say? Oh, there used to be a narrative that said, go on hormone therapy, but you can only stay on it for 5 years. That has absolutely been debunked. And in the 2022 position statement from the North American Menopause Society, it clearly states that there is no recommended timeline for when a woman should stop hormone therapy. It's a question that, because you're doing annual reviews with your prescriber, please tell me you're doing annual reviews with your prescriber. You want to make sure that that benefit versus risk conversation is happening at least once a year. So I just told you I have no intention of discontinuing my own hormone therapy, but I also have no intention of having a stroke. And so if I was to have a stroke or develop a health condition that prevented me from having a benefit list that's higher than my risk list, that's going to be a conversation that I'll have with my health team at the time. But for now, I'm 56 years old. I review it once a year, and I want to continue to have the benefits for my heart, brain, bone, and vaginal health. Is there scientific evidence that HRT reduces risk of dementia? Your question just preempted that one slide that I had at the end, and no, there isn't. There isn't any there hasn't been enough evidence or random controlled trials. And I don't know when that might be coming that would show that hormone therapy reduces risk of dementia. What we do know, though, is that estrogen and progesterone are very supportive of the brain. So when our cycles are regular and you're kind of like on, we know that that's been supported by the estrogen and progesterone that is being produced as part of our natural cycle. So I like to think of it as a protective quality, as an insurance policy, if you will. But as I said on that slide, we do not have evidence that shows that hormone therapy prevents either heart disease or dementia. What are the reasons for taking estrogen alone or estrogen and progesterone? Oh, good question. If a woman has had a hysterectomy but still has her ovaries, is progesterone recommended? Okay, I love this question. So we can take progesterone alone in perimenopause, then add estrogen for postmenopause. One of the reasons why you might only be taking estrogen would be if you had your uterus removed and your doctor did not prescribe progesterone. Estrogen cannot be taken alone by a woman with a uterus because estrogen cannot go unopposed. So you must. And it's one of the reasons in the Menopause Chicks community, I am constantly asking for more clarification. Do you have a uterus, right? Oh, I took estrogen and blank. Well, are you also taking progesterone and do you still have a uterus? Because estrogen cannot go unopposed. However, if you have had a hysterectomy, you can still benefit from progesterone because progesterone doesn't have one job. Its one and only job wasn't to regulate bleeding or protect the lining of the uterus. It is also very supportive of mood and sleep. It is it's an investment in our bone health and in our brain health. And there's hundreds of other roles that progesterone has in our body. So to say that a woman who doesn't have a uterus doesn't need progesterone is going to depend on two things. It's going to depend on your education and knowledge of progesterone and the quality of that hormone to a woman's health. And it's going to depend probably first and foremost on perhaps your symptoms. So if you are experiencing mood swings, if you're experiencing sleep disruption with or without a uterus, that would be a reason why you might want to explore on the pyramid if progesterone therapy would be beneficial for you. Hopefully that answered your question. Let me know if there's anything so I can clarify for you. Next question. I use Vagifem. So Vagifem is a brand name for vaginal estrogen. Can I also use Estrogel? There's a brand name for transdermal estrogen. The answer is yes. And you can take oral micronized bioidentical progesterone, brand name Prometrium. I use Vagifem 2 times a week plus hyaluronic acid moisturizer daily. It's helped with vaginal atrophy, but it's far from perfect. What could I add, change to improve things? Okay, great question. Here we go. First of all, hyaluronic acid is, I'm going to start with that. Hyaluronic acid is non-prescription. So I work with a number of women who initially follow the directions on the label, which is 1 gram per day. And that's what Health Canada makes us write on the label. But it is non-prescription and it is an incredible moisturizer and it's approved for the treatment of vaginal dryness from vaginal atrophy. So I want you to compare, if you don't mind me using this analogy, that you have really dry elbows. And the moisturizer says, moisturize once a day. Would you? Or would you probably moisturize your elbows 3 times a day or more, knowing that hyaluronic acid is restoring natural moisture back into your skin cells. And then once the dryness improves, you're going to remember to moisturize your elbows at least once a day. Maybe you'll go to every other day if the dryness really improves that much. So that would be where I would start. I like women to develop their own protocol for the moisturizing. Why do I start there? Well, because it's non-prescription and because you can create the amount of times that you moisturize on your own. Whereas with Vaginam or vaginal estrogen, it's a prescription product. And you might get a prescription for 3 times a week. That would be my next step. So you speak with your healthcare provider, say, I'm doing this and I need more support. Is there an option for me to use this prescription more times per week? Can I go from 2 to 3? Or can I change the dose? And that would be question number 2. And then if that doesn't achieve the goals or the outcome that you're looking for, come back or watch the Vagina Dialogues, because I lay out the entire menu. There are other options. There's red light therapy. There's a product called the V-Fit or the V-Sculpt is the name in Canada. And it's like a wand. It's kind of like a vibrator, but it has red light therapy that works to restore the collagen inside the vagina. And there are even some women who opt for laser therapy, which is not FDA or Health Canada approved, but there are many gynecologists and doctors who have the technology in their office. It has to be laser therapy done by a qualified practitioner. And the only thing that's not available for you is giving up. So don't give up. Try the moisturizer, ask about an increase for vaginal estrogen, look at other options that are available to you. If you want me to send you anything, I'd be happy to. Oh, thank you. Thanks for posting the interview with Dr. Pawa. I appreciate that. That's amazing. I have been on oral hormone therapy for 9 years. I am 59 years old. I come off a few times and went back on. That's interesting. What test should I request from my doctor to ensure that I'm getting what I need? There are no tests. It's really based on your age, your stage, your current symptoms, if you have any, and your health goals. So why are you taking hormone therapy? Is it, for genital urinary health? Is it for bone health? And having that conversation and that shared decision making with your prescriber is everything. You really can't test. There's really no use, because testing while you're on hormone therapy might just give you, a snapshot. It's like taking a Polaroid of that particular moment in time. And it's really about your experiences and the education and information of both you and your prescriber. I've heard hormone therapy can increase dense breasts. Yes, I probably don't have time to do a deep dive on dense breasts, but if you already have dense breasts, then you and your healthcare team are going to want to have that conversation. I've got some research. It's not in the position statements that I have been talking about tonight, additional information that I have from the North American Menopause Society that I have passed along to members. If you are looking to have a investigative conversation with your health team or your prescriber, I would be happy to share that with you. You can message me on Facebook Messenger to Menopause Chicks, or email me at menopausechick@gmail.com. Very, very cool. I'm glad. Okay, you had an appointment in September. September feels like a long ways away right now, but I know it's just around the corner. Let me know if there's anything that I could do to support you or get you ready for that appointment. Further to your comments, I would appreciate being pointed to an individual resource that, as you mentioned, I can add to my health team. Yeah, I'm happy to do whatever I can. The menopause.org, which is the North American Menopause Society has a listing of all the NAMS certified practitioners. It might look like a long list, but there aren't enough of them, in my opinion. There's about 1,000 in North America. We have about 1 billion women in the world reaching menopause by 2025. So you don't have to work with a NAMS certified practitioner. You might want to start there. Depending on where you live, I might be able to direct you to someone that I know. Yeah, so send me a message and I'll be happy to help you. Okay, cool. Thank you. What issues would affect the efficacy of your hormone therapy where you need to make adjustments as it isn't optimal anymore? Yeah, I don't really know about COVID or health issues or aging, but the number one thing that would affect efficacy of your hormone therapy would be compliance. It's a big deal. It's the reason why those messages put on the prescription products that we bring home from the pharmacy that scare us because of all the side effects that are listed there, when in reality those message warnings on hormone therapies are there. Well, one, they're legalese, they legally protect the manufacturer from patients who aren't compliant. So that would be the number one thing, taking it on a regular basis. I don't think there is any other information or data on the things that you mentioned, like aging or COVID, that would relate to mode of delivery. Mode of delivery just really refers to, all of these therapies are available on that chart that I showed you from Women Living Better. They're all available, but you want your prescriber and you to understand those that are going to be have the least risk for blood clots, for example, or the highest efficacy safety rating for protecting the uterus against uterine cancer. I mean, that's what did it for me. Like, yes, definitely oral micronized bioidentical progesterone. That's what I want. Because it has the highest efficacy for protecting my uterine lining. My doctors told me progesterone isn't used for improved sleep. I respectfully disagree. Okay, so I'm not in a doctor's appointment when a doctor says these things, so it's really hard to know the context in which they might have said it, but I'll just give your doctor the benefit of the doubt. Your doctor might have said that progesterone therapy is not approved as a sleep treatment. And that is true. It is not a treatment for sleep. What it is a therapy that gives your body back the progesterone it used to make on its own. And progesterone, when we have the amount that we need, is very protective, supportive of our mood and our sleep, and regulating bleeding at still have a period, and protecting the lining of our uterus. So you see sort of the fine nuance difference in the context of that. So I'm glad that you respectfully disagree. That's probably, I hope, maybe some of the information that you got here from Menopause Chicks. You're welcome. Can lost bone density be restored in any way, or is it lost forever? It's lost forever. Once we have osteoporosis, we have osteoporosis. The only thing that we can do is prevent further bone loss. Great question, though. Excellent question. Thank you so much for everything. Shirley, I have to go, but this was very informational. Okay, I know we went 20 minutes over, but I love your questions, and it really helps to improve future educational events. So thank you for doing this. Thanks for coming out. Do reach out if there's anything that I can do to support your health journey. And yeah, if you haven't already, go download the Menopause Masterclass, menopause-masterclass.com. You can check out all upcoming events. I'll have to update the calendar soon again, because I've just come through a busy, full couple of weeks, but check out menopausechicks.com, because that's where the list and the calendar always is. And you are most welcome. Thank you for putting your own name at the top of your to-do list. Good night, everybody.